Thanks for all the presentations, as usual, excellent. A question for, I guess, both Andrew and Olaf about people who are injecting drugs either recently or actively. Do you think that the ease of DA therapy is going to change people's concern about hepatitis C acquisition, sort of like we saw in HIV, where risk behaviors increased as therapy got better?
So my experience is that it has changed in those middle-aged people who inject drugs, who are starting to be concerned about their health. So we see those who come to our clinic are mostly 40 years old or older. And they are bringing their friends spontaneously without us asking them to do it. So it's happening there, but in the young community, those in the 20s, we don't see at all yet. So we will have to find that, and that will be the challenge, I think. I'm not sure if it's going to happen, but it could spread in the community as a good thing, and then it will do it by itself.
Yeah, Jordan, I reckon it's a great research question. We have a bit of data from the prisons. I guess I see the prisons as being a PWID population who have a higher proportion who are recent injectors. If we look longitudinally at what happens to the 70% of Australian prisoners who come in who report lifetime PWID, they cycle in and out of injecting. They often have a crescendo of risk before they go to prison, and then it's a bit messy when they arrive there and they're looking for where they might be able to access drugs. And then they move over periods of months in and out of injecting. In the people that we've treated traditionally, I think we've probably had a bias towards the individuals who are more stable, who are making the decision, this is it, I might try and get clean before I get out. And in that group, we found very low rates of return to injecting. I haven't formally looked at reinfection post-treatment. We are looking in the STOP-C study at exactly that issue. We've already found, for instance, in our surveillance phase, where we've got individuals who are in all the categories. So we've got individuals who are antibody positive and PCR negative, as well as individuals who are antibody and PCR negative, who are injectors, who are in prison. And what we've found is that we're getting reinfections after previous natural clearance, as well as primary infections at similar rates. So it's definitely a concern, I guess, is my sense of it. I guess I've learnt to not think of either the prisoner population or the PWID population as a homogeneous entity. They're very varied in agendas and issues, and it may well be that we need to target additional prevention strategies. We definitely need to target additional prevention strategies, but to some of those higher risk individuals, once we get them engaged in care, in some ways it's a window of opportunity to think about other prevention strategies. Maybe a vaccine, Andrew's going to tell us about.
Margaret?
I was going to sort of comment on that, Jordan. It's something, because I do HIV as well. I think there's this issue of will treatment, sort of lead to treatment complacency is the kind of words that are used in HIV, which I think is a word that is used very carelessly, because I think complacent is not quite the right word. But if one thinks about it, as a preference position, most of us, when we're having sex, would prefer not to use a condom. So it's not surprising when an opportunity arrives through PrEP and treatment as prevention in HIV that most people will go, my preference position would not be to use a condom and to not use a condom. And in fact, the data is still whiffy on that anyway. But if you just think about it personally, the preference position for a person who injects drugs is to use a clean syringe. And the only reason they don't do it is because we, as in the public health system, don't enable them to do it in a way that's simple. And it's not because they don't want to get HIV or hepatitis C, but they want to look after their veins. The vein is a primary thing for them, to have a clean vein to inject in. So to me, I think it's slightly different to the sex HIV situation, where the preference is not to use a condom. An injector will preferably use a clean needle if we let them do so. So I think we've got to I think we need a lot of data and we need to collect it, and reinfection will be an issue, but it's not like there's going to be I'll just share needles. Most of them don't want to share needles because of the vein.
It's really following up on what Margaret said, and
and Jordan has basically asked. It's challenging you, Olaf, a little bit, because you're coming across as, well, it's in theory, it's possible, but practically we can't do it. And I find this a little bit too discouraging, and from what you have been showing, I think we can push it a little bit more. We need to look at other interventions. We need to really try to find the better communication strategies to reach those people that are probably more difficult to reach, the younger guys. But I'm not happy with the conclusion that is sort of half-baked to say, well, you know, treatment prevention, maybe it works or maybe we can do it or not. We've seen this in HIV, that it can work if you reach high levels of coverage. Of course, with 50%, treatment as prevention is probably not good enough either. We're seeing HIV, unless it's 80% plus of coverage, it's not going to work, and obviously we need to have high levels of adherence beyond that. So I just don't want to walk away with that, well, you know, maybe not. I think we need to make it work, and I think we have probably other experiences from other areas where we say, this is what needs to happen in addition to what we're already doing, so can we make it work? Good community-based models, specific strategies for various groups, understanding it's a heterogeneous group, and obviously for the young ones, etc., etc. I just want to be a bit more positive.
Thank you. I should maybe correct. I'm optimist always, and I think it's worth doing that. But I think it's not going to be possible before the community is very engaged in this issue. And at the moment, I don't know. And it might change because we have to keep interferon totally out of this. And then hopefully that will change the attitude in the community, because the HIV epidemic was basically controlled by the community, at least in Scandinavia.
Can I just add slightly? I just think treatment as prevention in the prison setting, perfectly achievable, absolutely. It just needs political, organisational will to do it, absolutely achievable. Everybody in the prison system in Australia should be being treated. That's going to happen within 5 years.
I am Hussein from Iran. I'm wondering, how do you complete the therapy in prisoners who leave the prison before they finish their therapy? They are accessible? How do you follow them?
Yeah, well, thanks so much for the question. We're very lucky in Australia that because we have universal access to healthcare, to testing and to the medication, it's at least theoretically achievable to provide good continuity of care. So as Margaret flagged earlier, what happens in the taxpayer-funded subsidised DAA access is that the drugs are made available in 1 month lots of a typical 3-month treatment course. So we ensure that our inmates, when they leave prison, if they haven't already finished, they take what's left of the 1 month supply with them, and they take with them a copy of their script, which can be filled at a pharmacy outside in the community, and they take from us a letter that goes to their primary care clinician that says, so-and-so's at 8 weeks, 4 weeks to go, can you do these tests on this schedule? We haven't yet formally evaluated how well that runs. One thing to say about that is to not dismiss it as an insignificant issue. When we tried to achieve continuity of care in the interferon era, extremely difficult. I'm not sure how generalisable this is, but there are all sorts of other issues that just move completely to the top of the priority list when individuals leave prison. Housing, access to drugs, debt to our taxpayer-funded unemployment schemes, all sorts of stuff that really just get in the way of healthcare. And so getting that continuity is definitely still a challenge, but we're in a great position to make sure it does happen.
Do you test them for SVR?
Inside the prison, yes. When they're outside, we encourage their general practitioner to do it.
I take the privilege of being the chair of the session to ask 1 or 2 questions. I think it's a real challenge in many areas to get SVR12 for various reasons. In the general population study, like in Egypt, in Georgia, they do have the same problem. Sometimes a vulnerable population, they don't come for being tested. Have you ever considered the use of financial incentives?
Yes,
Because it's a
we
very
actually do
expensive
it.
treatment. Okay.
We do it as a research. So we give a voucher 10 euros, and it's amazingly effective. So for a long-term follow-up, we do that, and we feel that's necessary. So in research, we have very good experience with that. And I think it's fair, but it's maybe also a step in the wrong direction in this community to always pay people for good behavior. It is kind of you are introducing a new reflex in a way. So I'm a little bit concerned about doing it broad scale, but in research, it's very effective.
Well, I think it's very reasonable. Why you think it's not possible for general purposes?
I think
it's a cultural thing, certainly.
Yeah, there are a lot. It's a complicated issue for a doctor to discuss this, but there are a lot of issues in the life of a drug user, and if this is the right way to move forward, should be to be paid for good, healthy behavior. You learn something that's maybe not effective in the long or very productive in the long term in the life.
Okay.
I was just going to comment that we do it in other areas. So in vaccination programs with parents, we say we'll have reduced childcare costs. In Australia and in many places, we provide financial incentives in one way or another for good behaviour. I did it with my kids to make them wash up. I don't know whether any of them are drug users or not. I mean, I just do think we've got to... We are always reluctant to give people who inject drugs money. Mm-hmm. And in my view, the reluctance sits with they're going to go and use drugs. Yeah. I personally don't care. I mean, it's their choice. They have individual agency. So there's lots of evidence to show that if we pay people, including people who inject drugs, anybody, that they do better in health systems. I'm a great believer in paying people. But I pay the middle class and I'll pay the drug user.
There are huge experience in Russia and other countries using monetary incentive in respondent-driven sampling. This is one. In Athens, recently we had a huge outbreak of HIV, so it was very important to recruit as many as possible and in a very fast pace. We gave monetary incentive plus this kind of sampling, and we succeeded to enroll 90% of drug users of Athens metropolitan area, and I don't have any ethical problem. So I think you have to be very creative with this population because our focus always is the health problem. If we mixed health problems with preoccupations, with a lot of cultural things, probably it's not a good service for our society. Questions?
Questions, comments? No, okay, yes.
I was very impressed by the talk of Egypt, what you're doing with children. It's really great. I just wonder, you get the impression there is still quite some hospital transmission of Hepatitis C. If you look at children who were treated for malignancies, for example, is there a sterilization problem, or what is, or the testing problem, or I don't understand really.
No, there are still problems in the hospitals. We do have a program for infection control. Sometimes it's not very stringent in lots of hospitals because of the overload of patients and the numbers of patients being treated in those hospitals and the overcrowding. So it needs a lot of training and a lot of surveillance, which is still not happening efficiently as it should be. So we're still getting new infections, both from blood and nosocomial infections, for children and adults. We have an action plan that we worked on with WHO and CDC, and we started to train a lot of physicians and nurses in all university hospitals and other hospitals about guidance and new guidelines for infection control. Still, we have limited resources, and there is another problem is lack of legislations. We need legislations for enforcement of good infection control in hospitals, and we need legislations for clean blood. Our last blood law was issued in 1961, which is very, very old. So we're still waiting for new legislations to be able to force or enforce a good practice and to enforce good blood safety in the country. It's much better than before. People are getting better, but it still needs a lot of work.
Thank you. Do you perform FibroScan in prisons? And if yes, cirrhotic patient usually needs 6 months therapy. How do you treat them? It's very difficult to follow them for 6 months or keep them in the prison or like.
Yeah, good question. We're lucky enough that one of the things that we found when we were developing our model of care was that the custodial authority was very interested in how it could save money. And so we said to them, look, every time we're forced to send an inmate, a prisoner, out to a hospital to have their FibroScan, it costs you a guard, 2 shifts, 2 individual guards to go out and take them and bring them back. And we worked out at the rate that we were doing the FibroScans, we could easily save the custodial officers a lot of money. And so they bought us a portable FibroScan. And so now we fly that around the state and do effectively FibroScan clinics. Actually, we've already found that, a bit like Margaret was flagging, we're operating really a triaged selection system using APRI scores to triage those that go on to FibroScan. What we've found in our data so far, though, interestingly, is that the pattern of fibrosis stage in the prisoner population, it's almost dichotomous. So there's a great majority that are somewhere F0, F1, F2, and then there's a small minority, about 20%, that are F3, F4, largely unsuspected, that argue strongly for the need to assess for fibrosis and to prioritise those individuals for treatment. So I guess there's a take-home message: if you're working in a prison system, try and convince the custodial authorities it'd be a good investment for them to buy you a FibroScan.
Other comments? We have a few minutes.
But maybe depending on genotype, but you don't need half-year treatment even in cirrhotics.
Now, I'm curious to know if you think it's feasible and if there are any plans to do a mother-to-child transmission study, particularly in HIV co-infected women.
Yeah, I think it's feasible, and we're trying to get some funding for this. Actually, with University College in London, we've been trying. It's been rejected several times, and hopefully we'll get the funding at some point, because it's they have the co-infected group and we do have the mono-infected group, and we were thinking about doing something to prevent mother-to-child transmission. I think it's absolutely worth it.
Have you looked at what type of sample size you need to do it? With the mono-infected population, I would think you need a lot of women. That's the challenge.
Yeah, but I think we do have the prevalence. My hospital, for example, we have 2,500 deliveries a month. So it's one of the big hospitals. So it's easy to get a hospital with 3,000 or more deliveries a month. And the population is increasing by 2.5 million every year. So you can imagine it's easy to get some of the HCV infected cases.
So there, Jordan.
No.
Okay. Anything else? Okay, we start.
Thank you very much.
Thank you very much.